all of you. A warm welcome to our Zoom webinar organized by GMOA Sri Knowledge Academy. Today our lecture is going to be on approach to chest pain in emergency department. Kindly mute your microphone and turn off your camera during the presentation, and you can use the chat box to clear your doubts at the end of the session. Now it's my pleasure to introduce Dr. Chamara Berugodaarachchi, Acting Consultant Emergency Physician attached to District General Hospital, Chilao. Over to you, sir.
Perfect. Thank you. And good morning, everyone. And thank you very much for giving me this opportunity. And my sincere thanks to GMO and Sri Knowledge Academy for initiating this very nice and timely program to uplift the knowledge in between doctors, knowledge, attitudes, and skills of the doctors. And I think it's a great pleasure for me to share my knowledge and skills with you. At the same time, I gain lots of things from similar programs which has happened in the past. So today, the topic I was given is the approach to chest pain in the emergency department. So I am supposed to talk about this approach within next 1 hour. Let's see how to do that. I will start this talk with a sad story. A couple of years ago, when I was at first year registrar, there was a male in his mid-40s came with typical chest pain. I will describe what is this typical means. Typical chest pain, normal vitals except hypertension, and he has got inferior myocardial infarction in the ECG. And he didn't have any difference in the blood pressures. He complained of some back pain, but it was not that convincing to say that's radiant through to the back. And we didn't have any focus or point of care ultrasound scan facilities at that time. And so we finally decided to give fibrinolytics with streptokinase since we don't have PCR facilities. We gave fibrinolytics, and patient chest pain did not resolve, and patient ECG changes were persistent. So we transferred the patient to cardiology unit for rescue PCR. Couple of days after, actually one of my colleagues, senior colleagues who was a cardiologist registrar, met me and told me, "Thank you very much for the referral, but unfortunately patient is no more." The reason has been that they have found, maybe I think after the angiogram, grade 1, type 1 aortic dissection, and they have tried some cardiothoracic referral, but unfortunately they couldn't save the patient. So I'm pretty sure most of you might have similar story like that, and I have some couple of other stories as well I will tell in between the lecture. So every one of us can make some errors because this is a very tricky presentation, and there can be lots of overlaps and mistakes. So keeping that in mind, let's see what is my approach, or what is the emergency department approach to chest pain. Basically, we are worried about chest pain due to various reasons. The first thing is it's common. It's very common. The international data suggests that it is one of the most common ED presentations in the European and developed countries. In a study done in 2016 in Clinical Hospital, they found that out of 50,000 annual admissions for the emergency department, about 55% were medical admissions and 34% of admissions were related to chest pain. So that's a huge amount, huge. And so that these patients are our patients. Those are the patients with chest pain. And the other thing, we know that the chest pain can arise from anything. It can be due to a problem with the organ or system in the chest wall or the chest cavity. It can be heart, it can be great vessel, it can be the lung, it can be the pleura, it can be the esophagus, it can be the chest wall, and it can be some inter-abdominal organ like pancreas and the gallbladder, stomach, and it can be something distant due to referred pain. So it can be of anything, any organ or any system. And out of these causes, most of the causes are benign. Few are fatal. how to identify these fatal illnesses from benign causes. And we all know that the visceral efferent systems of our chest wall, they have overlaps, so that from the type of the pain, from the associated symptoms, we can't exactly say this pain arising from this pain arises from the heart, this one is the esophagus, this one is from the pleura. So there are lots of overlaps. And even though I'm going to discuss about typical presentations, there are lots of atypical presentations. So the atypical presentations are typical. And as you all might know, so we are in the process of introducing the emergency medicine concept to this country, which is in developed world. The emergency departments are meant to identify critical illnesses in the patient and stabilize them and start appropriate management and hand over to the inpatient specialists. But at the same time, we are expected to discharge patients without significant illness, patients who are having benign pathologies. How to do that? It's very tricky. That's why it's said that out of 6% of discharge from the UK emergency departments, and this is one study, subsequently they were found how 6% of them found to have significant, prognostically significant myocardial damage. So errors can happen. Our idea is to minimize errors. Let's see how we are going to do that. So I said there can be many causes for chest pain. So some are imminently or potentially life-threatening. So we need to identify them, we can't miss, and we need to quickly and robustly manage them. On the other hand, there can be some benign pathologies. Only thing we need to do is send them home with some reassurance and with some safety network. And there are some other causes which have specific identifiable cause which has to be managed, maybe in the emergency department, maybe in the inpatient ward, or maybe able to discharge with some treatment. So there are some other categories as well. So our idea is to identify these three categories as much as we can without compromising patient safety. So as I mentioned, the causes for chest pain can be cardiovascular, pulmonary, musculoskeletal, gastrointestinal, or anything, any other thing. Out of these things, the most worried diagnoses are these fatal things, big six: acute myocardial infarction or acute coronary syndrome, aortic dissection, pulmonary embolism, pericardial tamponade, tension pneumothorax, and esophageal rupture. And there are some urgent condition which should be identified, like pericarditis, unstable angina, simple pneumothorax, pancreas. Even though they are not immediate life-threatening, they have to be managed. And there are some non-urgent causes as well. We will go through these diagnoses as much as we can, as time permits, and see how we can minimize errors. Okay, now we are going to the assessment part. If you want to take one take-home message from this lecture, keep this circle in your mind. So this is the most important thing in my lecture. So the assessment of a patient with chest pain. Since you have already had some couple of emergency medicine related lectures in the past, you might have heard about the approach to a critical ill patient or the emergency department patient. So chest pain is a critical symptom. It's a concerning symptom. So all the patients from the emergency department, so we are now implementing the RAD system in most of the hospitals. So it's in the process. So they have to be categorized. Chest pain, symptom-wise, it's a category 2 urgent patient. If they are having some hemodynamic compromise, they will be category 1, but this is definitely a category 2 presentation. So they are prioritized. So they have to be taken to a bed and monitored bed and do the initial stabilization. And then after the patient is stabilized, A, B, C, D, E. We have going through the directed history and examination of the stable patient. And from that directed history and examination, we can have some idea about the risk of the patient for a particular disease so that we can guide the relevant investigations. And from the investigations with the history and examination, we can go for the definitive management. And then we can think of the ongoing care and exposure, whether we send the patient home or whether the patient is going to the ICU or to the board. Now let's see how we are going to do this initial stabilization. For example, patient is coming with chest pain. So triage category 2, initial stabilization. So if the patient comes with chest pain with severe dyspnea, we have to prop the patient up. If the patient comes with severe shock, we have to keep the patient lie down. So that is a position. And we have to assess the airway, whether it is patent, whether the patient needs additional oxygen. Any critical equation, we can give oxygen. And later we can reduce oxygen if the patient is diagnosed with myocardial infarction and the saturation target is 95. That's a different thing. But if the patient is a critical intubation, assess the airway, administer oxygen, and stabilize the airway. And breathing. What is the respiratory rate? What is the air entry? What is the saturation? What is the work of breathing? Assume the patient comes with respiratory rate of 40 with unilateral absent breath sounds, hyperresonant chest, blood pressure 80/50. This patient is having a tension pneumothorax. So initial stabilization means before going to the directed history, we identify a life-threatening, imminently life-threatening condition like tension pneumothorax. So we have already covered one of the big six, one of the major causes of chest pain, fatal causes, tension pneumothorax in the initial stabilization. We don't need anything. What we need is just methodical approach for the initial stabilization and assessment. So once you identify tension pneumothorax, you don't need the decompression. And that's it. It's done. And then you go for the circulation. Assume the patient comes with heart rate of around 180, 200, and blood pressure 80/50, drowsy, and patient have the, when you connect the patient to the ECG monitor, you get this. Don't wait the ECG technician to come and give a ECG of a VT or ventricular fibrillation. If the patient is having compromised circulation, that has to be addressed with the cardiac monitor. You can diagnose VT with the hemodynamic compromise and manage that with a synchronized DC cardioversion. So you don't have to wait for the ECG technician to come and do an ECG and show that ECG with a VT, or definitely not the ECG of a VF to find out that the patient is not breathing. That's the importance of initial stabilization. And then assume the patient comes with a heart rate of 25, blood pressure 70/50, and drowsy, and we don't know what's going on, but this patient needs to be managed immediately in bradycardia algorithm. If the patient is stable, yes, you can have as soon as possible to get an 12-lead ECG for the diagnosis of what is the block patient is having. But the initial stabilization means you identify immediately life-threatening causes and manage it at that point. And then disability. What is the GCS? Whether there's any posturing. If the patient comes with chest pain, having some low GCS, that is not typical of an MI. Something wrong is going on. So exposure like that. So that is the part of initial stabilization. Assume now we have stabilized the patient, gone through the ABCD approach, and we have identified we have stabilized the patient. And then directed history and examination. Now this patient comes with chest pain. So the presenting complaint is pain. And in our medical school life, we are told that we have to take a comprehensive pain history with the Socrates. pneumonia. I never understood the importance of this directed comprehensive history in my medical school life. If any one of my colleagues is hearing this lecture, they will agree with me. I never understood that until I got to know that that is the only way of escape in front of a critically ill patient, most of the time. So the history, even though we are working in emergency department, we can't work as robots. We have to take comprehensive history for the risk assessment and to identify the pathology behind. So that is very important. So the Socrates, it's very important. Ask when this pain started and what were you doing while this pain, whether you were watching television, whether you were gardening, if you were gardening, whether it's a strenuous work or whether it's a light work like pruning, and how did it start? Whether it started very rapidly or whether it gradually developed over time. And what is the character? Whether you feel like an elephant sitting on your chest or whether it is something very sharp. And where does it radiate? What are the associations? Whether it is nausea, vomiting, diaphoresis. And how this pain has evolved over time. How long this initial chest pain lasted. And what do you do for that? Did you take any medication for that? And how many times from the time of onset, how many times did you have the similar pain? And whether there's an exacerbation or relieving factors. And the severity, if possible, to get a numerical scale to rate this pain out of 0 to 10. That is important. So that is the pain assessment. From that history, you can have some idea. This pain sounds like this pathology, sounds like this, sound like this. We can put into some box of etiology so that you have some idea where I'm going. And then in the history, then we assess the risk factors. What are the risk factors if this patient's pain is suggestive of acute coronary syndrome? So what are the risk factors this patient has? And if this pain sounds like pulmonary embolism, so what are the risk factors? So risk factors analysis, then that is the next step. And then we can shortlist your differential diagnosis. And then you can go for the directed examination. Let's see how we're going to do that. And then we can shortlist. And a couple of the most important questions I usually ask is whether you have similar pain before. And what do you do for that? Whether you were investigated, what are the investigation findings? If the patient has got a similar pain in the past and he has got a stress test and full comprehensive cardiac workup and found to be normal, that is reassuring, not 100%, but it's reassuring. And like that. So whether the patient has got recent bypass surgery, whether the patient has got recent PCIs, that is very concerning in that case. So like that history is important. And risk assessment, as I mentioned, if it is a cardiac cause, slightly cardiac cause, there are heart score, TIMI score, gray score to just guide us. What are the next step of management? What is the next step of investigation? What is the next step of disposition? If it is a pulmonary embolism, what's the Wells criteria? What's the Wells score? So we'll discuss very briefly. And so basically, while we are assessing a chest pain, the ECG is number one, and then chest X-ray is very helpful. And now in emergency department, we have got point of care ultrasound scan, so that for most of these pathologies, we have some kind of go in the point of care ultrasound scan. So it is been widely used, and troponin and ancillary investigations guided by history, examination, risk assessment. That means whether we are going for CT scan, we can't do CT scan for everyone. So we have to very carefully identify who needs a CT scan, who needs further investigations. So that is the basic workup of any patient with chest pain. Right. And now we will go for the next step. So the big six, the most fatal big six. Okay. So as I mentioned before, Big cyst means acute coronary syndrome, so it should be corrected as acute coronary syndrome actually. And aortic dissection, pulmonary embolism, tension pneumothorax, pericardial tamponade, and esophageal rupture or medius stenoitis. So I will go through these topics briefly. I'm pretty sure during the near future you will have dedicated lectures for each and every condition, so that I will not be able to address and cover full myocardial infarction, full pulmonary embolism from this lecture. So it's not a part of this lecture, the scope of this lecture. And we'll go through briefly, highlighting on the historical examination and risk assessment parts of identifying these illnesses in the emergency department. Fine. Acute myocardial infarction or acute coronary syndrome. Acute coronary syndrome include unstable angina, non-STEMI, and STEMI. So definitely these patients need to be admitted and they have their own specific management. Stable angina also, if it is concerning, might need to be admitted. So how to identify acute coronary syndrome? History is important. The textbook description of acute coronary syndrome is an elephant sitting on my chest, a dull ache, or the retrosternal pressure in the center of the chest, maybe towards left side, with sweating, with some nausea, vomiting, with some radiation. So that is the textbook. And there are a number of studies done to assess the likelihood ratios of these symptoms. So let's think a little bit statistically and think what are the sensitive features of this textbook description. We'll start from the bottom. So as I have mentioned here, if the likelihood ratio is more than 10, that means it's strongly suggestive of that particular pathology. If it is more than 5, it's good evidence. If it is less than 2, moderate evidence. So from those likelihood ratios described as pressure, retrosternal pressure, tightness or constricting type pain has some sensitivity, but not strong. It is worse than previous angina or similar to previous MI. That is the important point in the history. Associated with nausea, vomiting, associated with diaphoresis. Those are the symptoms of critical illness. Whatever the reason, those are symptoms of critical problem going on. So those are also sensitive, not specific. And radiation to left arm. So textbook normally says pain to left arm. That is a little bit lower down in the likelihood ratio risk. Radiation left arm is sensitive, but not. But the radiation to right arm or radiation to the both arms are more sensitive than just radiation to left arm. So if the patient comes with chest radiation to right arm, that is more sensitive than radiation to left arm. And if the patient is assured with exertion, again, it's a positive factor. So as you can see, any of these likelihood ratios does not exceed 10. So that means you can't rely solely on these historical features to rule in chest pain, rule in acute coronary syndrome in a chest pain patient. On the other hand, decreased likelihood. If the patient present the pain, describe the pain as pleuritic, if it is positional, if it is sharp, if it is reproducible with palpation, if there's any inflammatory location, if there's no association with exertion, if there's an associated palpitation or associated syncope, those are sensitive to exclude acute coronary event. But again, none of these features cannot exclusively rule out acute coronary syndrome. Even though patient present with pleuritic pain, it can be, but the likeliness of acute myocardial infarction is less. but you can't exclude. There are some other features we normally hear when we are doing the word round. This pain sounds like burning type pain. This pain has improved with GTN, so it's unlikely a myocardial infarction. It has this patient has an abrupt onset of pain. So according to the available studies, these features does not have any meaningful effect to rule in or rule out acute coronary syndrome. So basically, you can't take any decision based on these features. But the previous decision, previous symptoms, you can have some idea, but not 100%. So basically, no single factor in the history alone can confirm rule in or rule out acute myocardial infarction. And as I said, atypical symptoms are typical. Especially, this is not to discriminate, especially in women, in elderly, in diabetics, you can see lots of atypical presentations. There are some literature saying that about 1/3 of the patient may present without chest pain, especially these categories. They can come with dyspnea, weakness and extreme fatigue or lethargy, syncope, or altered mental status, and sometimes maybe just with chest pain, maybe just with sweating. A couple of weeks ago, very recently, I had a patient, a female patient in his 50s, coming with severe positional pleuritic and pain. She shouts, she screams with palpitation. Ultimately, found to have an extensive anterolateral injury. So that is not uncommon. This is very common. Risk factors. So I'm not going to go through these risk factors. These are the normal, conventional, and unconventional cardiovascular risk factors that are important for the risk stratification as well. And then examination. Most of the time, these acute coronary syndrome patients have no positive examination finding except if they have developed heart failure or shock. So basically, it's not that helpful, but there can be some evidence. ECG. So basically, within 10 minutes, any chest pain has to have an ideal then ECG. What you look at is new ST segment elevations or depressions, new Q wave formation, new conduction deficit, like left bulbar clock, and T wave peaking or T inversion. These are sensitive, not specific. And depending on these features, you can categorize this patient as got whether he has got an occlusion MI, or whether he has got a semi-equivalent like Collins, D winters, or something like that, and whether the patient was non-STEMI, so that I'm not going to go into detail of the ECG analysis. So I think I'm pretty sure it will be covered in another lecture. And important thing is normal ECG does not completely exclude a patient an acute myocardial infarction or acute coronary syndrome in a patient who is having chest pain, suggestive chest pain. Again, chest X-ray, you can take it, but it's basically to rule out other diagnoses. And troponin eye, you have conventional troponin, you have got high sensitivity troponin, and now we are in the era that we are talking about delta troponin or the change of troponin levels. So those can be used, and the focus or the point of view ultrasound scan can be used to see the signs of heart failure, and we can see the ball motion abnormalities to help with our ED decision making. And it is very helpful to explore the causes as well. Okay, so based on the diagnosis, whether it is STEMI, non-STEMI, you have different pathways of management, so that I'm not going to talk about that. It's beyond my scope of the lecture today. So I'm pretty sure you will have a separate lecture for that. But you now know patient has got a significant so that you will not send the patient home. And if the patient is having obvious STEMI, obvious transit, that is a different thing. If the patient is having very benign pathology, it's a different thing. In between, there are patients whom we can't take a decision. What is the risk for this patient to have a major adverse cardiac event? So there are a number of scoring systems we have been using in the past. Basically, we are well aware of TIMI score, GRACE score, but HEART score and EDEX score, those are more emergency department oriented. And those are HEART and EDEX score are addressing the chest pain patients, as opposed to TIMI and GRACE score, where we address already established diagnosed acute coronary syndrome patients. So what we need to do is to risk stratify these patients to see whether what is the risk of this patient of having a major adverse cardiac event within next six weeks or 2 months. Major adverse cardiac event means either death, either myocardial infarction, or revascular strategy, so that we will be pretty sure if we are sure. We will be pretty confident and pretty comfortable if we are pretty sure that the patient belongs to a low risk category based on these risk stratification tools. So I will not go into major detail, but just to give you a small idea of the HEART score. HEART stands for HEART. So history. So that is the history part comes into play again. So whether we feel that this patient has got a suspicious history or not. What are the ECG changes? What is the age? What are the risk factors? What are the troponin levels? So based on that, it is giving some score. If it is less than 3, that means low risk category. The chance of major adverse cardiac event is less than 2.5 with the help of new high sensitivity troponins. It has come down to 1%. Actually, those are the patients, if we have a proper follow-up mechanism, those are the patients we can think of discharging from the emergency department. As I'm aware, in some of the emergency departments in our country where emergency physicians are working, they are using the HEART score, and at the moment, I'm also trying to implement this full HEART path in my hospital, but there should be some kind of system and space and to keep the patient for investigation systems and the follow-up mechanism to be arranged for full implement. But this is the history. This is going to be the future of emergency medicine, so that these patients will be re-stratified in the emergency department and discharged more and more in the future once the infrastructure and adequate facilities are available, especially with the proper referral or proper safety net to make sure that we don't miss any patient and don't have any adverse outcome from discharged patients. But this is one of the hard pathways being used, so that that is one pathway, but there are some different pathways as well. So just to give an idea, if the patient is low risk, there's a possibility that patient could be discharged once the system is placed and with the appropriate safety network. Okay, aortic dissection. We have got another around 25 minutes. Fine. Briefly, aortic dissection is a rare fatal illness. Incidence is 3 per 100,000 patients per year. And what happens is, basically, you get a damage to the intimal layer of the aorta, and the blood seeps through the intima and the media to create a false lumen. So most of the time, this is due to a damage to the intimal layer, and sometimes, not very often, it can be due to a rupture of the blood vessel inside the aortic wall, vasa, vasorum, or venorum. And this dissection or the collection of blood can propagate between the intima and media of the aorta, and the driving force is high blood pressure and tachycardia. It's like hammering a nail to a wall. So whenever you hit the nail, it will go in like that. In a patient who has got hypertension and tachycardia, that shear force can dissect the intimal and medial layers and propagate this dissection. And based on the area, based on the affected part of the aorta, that can be divided into type A and type B. Type A means it is involving the ascending aorta, and type B means it does not affect the ascending aorta. The problem here is once this dissection propagates, on one hand, that will narrow the actual lumen of the aorta. On the other hand, it will block the branch arteries of the aorta, maybe the coronary, maybe the vertebral, carotid, and subclavian, maybe the renal. So that will give rise to the symptom profile. That is a brief description of the aortic dissection. And in the history, the typical presenting feature is sudden onset, sharp tearing and ripping pain. It is something like, it is sometimes described as subarachnoid hemorrhage of the chest. So sharp, sudden onset, severe pain of the chest, which radiates to the back, and it can migrate, and it can present with neurological deficit. As I mentioned, it can evolve the other branches. It can present with neurological deficit like stroke, hoarseness, or sometimes altered conscious state. It can present with acute coronary syndrome. It can present with mesenteric ischemia. It can present with kidney stones. So kidney stones, so that if the patient present with chest pain plus something else, always suspect aortic dissection. Chest pain plus drowsiness, chest pain plus neurological features, chest deficit, chest pain plus abdominal pain, chest pain plus urinary colic-like pain, chest pain plus hematuria. Always think of aortic dissection. And the risk factors. I am not going to go through all these risk factors, but those are basically acquired or congenital conditions that weaken the structural architecture of the aortic wall. That's how that shear force can damage the intima and dissect through the intima and medium. On examination, these are sick patients. They are diaphorasic, they are hypotensive, they can be hypertensive, and they can be tachycardia. And differential blood pressures of right and left arm present in about one-fourth part of the patients. Pneumonia, especially aortic regurgitation murmur, can be present, and focal neurology signs can be present in 12%, not much, so that always need to keep an suspicion to diagnose that to miss patients who present with acute myocardial infarction with an element of aortic dissection. ECG can present, can have typical STEMIs, can have non-spaghetti or T-wave changes, and chest X-ray have multiple features like wide mediastinum, globular heart shape, and pleural effusions. Trachea can go to the right side, and left main bronchus move inferiorly. And but about 10% might have normal chest X-rays as well. And definite diagnosis is with the CT autograph or MRI or transesophageal echocardiogram, as seen here. This is the intimal flap sign, where you can see the true and false lumen with the dissection part. So post-focus point of care ultrasound scan is helpful to identify. Sometimes you can see the dissection part, but most of the time you can see pericardial effusion, so pleural effusion with focus. That once diagnosed, so I'm not going to go into major detail in the full management of aortic dissection, but basically you have to resuscitate this patient. As I mentioned, hypertension is not good, tachycardia is not good, so that you have to reduce the blood pressure with the target of 0 blood pressure 120 to 100 and pulse rate target to 6 to 80. So the best drug is IV beta blockers. What we have is labetalol here, and then we can start on vasodilator, not to start vasodilator first because that can cause reflex tachycardia and make the things worse. And then this cardiothoracic emergency, urgent referral is the key. And there are some risks also the aortic dissection as well. And as you can see, basically those include predisposing factors I mentioned, and pain features I mentioned, and physical exam findings I mentioned. So based on that score, each and every component of this table carries a mark. Depending on that, we can see whether the patient is of low risk category, which we can do a D-dimer test to rule out. And if it is high risk, we have to go for the CT angiogram if it is high risk, or if the D-dimer is positive. And this D-dimer adjusted ADDR score is not that externally validated, but that can definitely give some idea of the risk assessment of this patient who are having a suspicious pain. Okay, tired of aortic dissection. Now moving to the pulmonary embolism. So basically, again, about a couple of years before, when I was doing my foreign training, I had a female patient in her 50s who is a known patient with breast cancer on the chemotherapy, active chemotherapy, coming with fever, right side pleural chest pain, cough and fever. So obviously, that sounds to me like pneumonia with neutropenic in a neutropenic patient. Took an X-ray, that is not that convincing, but she's in tachycardia and fever, so that I was not too bothered. I started on antibiotics and doing fluids and everything. But later, and she didn't have any other features, so she didn't have swollen legs or anything. But later, she was found to have a right side pulmonary embolism. The key is I was completely diverted with the history of fever and some lung signs I heard, so that even though she didn't have signs of PE, she has got an important risk factor, that is active cancer. So I could have thought of that. The patient was fine, but it was there was a couple of hours of delay for the definitive diagnosis. So that can happen. So they can present with some atypical symptoms. Let's see what is the historical and examination features of pulmonary embolism. These are not that uncommon. These are basically the Western data. I don't know. Actually, we don't have much of evidence to say. In Western countries, there are lots and lots of pulmonary embolism cases. We don't know whether we are underdiagnosing or whether actual incidence is low. But we don't see much here. But always we have to suspect. So pulmonary embolism, they usually present with dyspnea. They can have to do chest pain and substernal chest pain. They can have cough, hemoptysis, and they can present with syncope, maybe without chest pain, just syncope. And risk factors. This is important for risk stratification. So I will discuss about these risk factors when I'm talking about risk stratification. So basically, the history of thromboembolic disease, pregnancy, family history of venous thromboembolic disease, prolonged immobilization, major surgery within previous 12 weeks, especially lower limb surgeries which last more than 30 minutes, and pelvic surgeries, and fractures of the lower limb, and active cancer. And the examination, they are tachypneic. They can be tachycardic. They can be hypotensive if they have in high risk or major cell pulmonary embolism. They can be hypoxemic. And JP can be elevated if it's a big emboli. Pleural rub, if you are lucky enough to hear that in the busy emergency department, you can hear that. And there can be some focal wheezing signs, and there can be some evidence of DVT as well. Okay, investigation, ECG. So most of the time what you can see is sinus tachycardia, nothing else. But there can be some evidence of right heart strain. I have suddenly muted. So can you hear me now?
Can hear.
Hope so. But, sorry, I don't know where I got muted. So did you hear this slide or did you hear the last slide?
So starting from the ECG, I think.
Perfect. Sorry, I think I pressed the button. Right. So basically, ECG features are most commonly you can have sinus tachycardia, and you can have some right ventricular strain patterns, T-wave inversions in lateral and inferior leads, complete or incomplete right bund branch block, right axis deviation P pulmonale. You will not be able to see this typical textbook S1Q3T3, and in this ECG you can see this S1Q3T3 pattern, but it's not that common. And patient can present with atrial fibrillation, flutters, and tachycardias as well. Chest X-ray, most of the times it is not that diagnostic, but this X-ray is actually one of my patients who present with typical history of cholecystitis. He came with right hypochondrial pain and having tenderness over the gallbladder, and morphine sign is positive. So initial blood workup was done, and I arranged an urgent ultrasound scan. Meantime, for the completeness of the investigation, I did chest X-ray to see this wedge infarctions of the right side lung. These are wedge infarctions. Those are called Hampton lumps. So she had the big emboli in the right side pulmonary artery. So that those atypical presentations are there. So it's interesting but very tricky. Okay, so again, with the focus, we can see right heart strain, or sometimes we can see wall motion abnormalities, and sometimes DVT especially. If you can't move a patient out of the emergency department who is peri-arrest or who is in arrest due to pulmonary embolism, these signs are very important. So if you can see dilated right heart with your scan machine, even though we don't have dedicated proper ultrasound or echo, you can have some idea of what's going on with the DVT scan and the point of care echocardiogram to resuscitate these patients accordingly. So that is very useful. Okay. Workup. As I mentioned, if the patient is having high suspicion of PE with hemodynamic compromise, that means patient is having high risk pulmonary embolism. If the patient's hemodynamic status is normal or okay, that patient have non-high risk presentation. Those non-high risk presentations should be risk stratified in order to direct appropriate investigations. So I think you have heard about revised Geneva score and Wales score. I'm fond of Wales score. With the Wales score, you can stratify the possibility of this patient having pulmonary embolism, then whether it's low, whether it's moderate, or whether it's high. If it is low, you can apply PERC rule, pulmonary embolism rule out criteria, to completely exclude PE. If it is not possible, you can go for the D-dimers, and if it is positive, for the definitive investigation modeling. Most of the time it is a CT pulmonary angiogram or VQ scan. If the patient is high risk, usually you directly go for the imaging. So that is a brief overview that have lots of other factors to be discussed. So I'm not going to discuss in detail. And so this is the criteria to rule out, and this is a Wales score. So those are the basically these are touching upon the risk factors I have mentioned and the typical clinical features to give them a score. Fine. For the in summary, treatment-wise, if the patient high risk or the patient is at hemodynamic instability, so you have to go for either thrombolysis or fibrinolysis, this place, or surgical or catheter-directed embolectomy. If the patient does not have hemodynamic compromise, you can start anticoagulation. That is the end of pulmonary embolism. So we have got 3 more. Tension pneumothorax. So we have already managed tension pneumothorax stabilization, but tension pneumothorax can be spontaneous in a healthy lungs, which is primary, in unhealthy or diseased lung, this is secondary. In traumatic chest injuries, so you can see lots of pneumothorax, but I'm not going to cover the traumatic aspect at all today. And the history is very brief: sharp subnonceptive unilateral pluripotent chest pain. And then risk factors for the spontaneous pneumothorax: smoking, tall, thin patient, marfans, pregnancy, familial pneumothorax, or past history of pneumothorax are risk factors. So basically, I think I don't have to re-emphasize the clinical features of tension pneumothorax. So I think I have already mentioned that during the ear stabilization part. So I think it's a clinical diagnosis. You don't have to wait for chest X-ray. You don't have to see this X-ray in the emergency department. So that is not good. Actually, this has to be identified clinically and managed. So if we have focus, it is helpful in identifying the possible pneumothorax. If you have any doubt, you can go for the lung sliding, absence of lung sliding, lung point, barcode signs, and everything. But so that's helpful. And ED management is basically if the patient is having needle decompression with a needle decompression. Now the current evidence suggests the use of fifth intercostal space mid-axial line, that is the safe triangle, rather than the second intercostal space mid-axial line, which is most of the time mentioned in our textbooks. So my first go would be the fifth intercostal space mid-axial line rather than the second intercostal space. And this has to be always followed by intercostal catheter with underwater seal. Okay. Pericarditis, myocarditis, myopericarditis. Most of the time, these patients present with myopericarditis and pericardial effusion with tamponade. So the pericardial effusion with tamponade is the life-threatening cause. So they usually present with the symptoms of pericarditis with the symptoms of tamponade. So basically, pericarditis pain means atypical, pleuritic, retrosternal, positional pain. So that does relieve while we sit forward. So if the effusion is there with tamponade effect, there can be some dyspnea, dizziness, and signs of hemodynamic collapse. Causes pericarditis can be maybe infective, maybe malignant, maybe uremia, so that I'm not going to go into detail, but it can be anything. The cause, the actual reason for that effusion and the pericarditis has to be investigated later, but what we have to manage here is the pericardial effusion with tamponade. So they can be tachycardic, they can have fever, pericardial rub. If they have myocarditis, they might have signs of heart failure as well, like gastric gallop and elevated JIP. If the patient is having tamponade, that patient can go into obstructive shock with pulses, paradoxes. Dextride, you might have heard before, hypertension, muffled heart sounds, and raised JVP. And ECG can show signs of pericarditis changes, diffuse PR segment depressions, and ST segment elevation, saddle shape, widespread saddle shape, ST segment elevation in most of the leads, except in AVR, where you can see reciprocal change, that is ST segment depressions and PR elevations. And if there's any effusion, they can now decrease voltage and they can have electrical alternates as well. Chest X-ray may reveal the globular heart, and focus is very helpful in these instances to identify pericardial effusion or tamponade, and especially for training purposes. So the management is urgent needle pericardiocensis, depending on your the facilities in the emergency department in the hospital. You can decide who is going to do that, but it's an emergency procedure to be done as soon as possible. And then we can decide what is the reason for that, what are the management for pericarditis with strict monitoring of this patient, because these patients can have these effusions reaccumulated. So they have to be monitored very closely. Fine. Last of the big six, mediastinitis, esophageal rupture. So the sudden onset chest pain might indicate an esophageal rupture. Basically, if the patient presents with sudden onset chest pain followed by a forceful vomiting or retching, that is suggestive. That pain is typically pleuritic and positional, and they can have associated odynophagia and some lung signs as well. So the patient who have got recent upper GI endoscopies or any other instrumentations are at high risk. Sometimes patients with odontogenic infections can cause mediastinitis without esophageal perforation. So they also can with signs of mediastinitis. They are ill. They might have evidence of septic shock, tachycardic, febrile, and so they can have subcutaneous emphysema. They can have some tenosynovial gastric region. Hammond sign, if you are really lucky in the emergency department, you might hear a systolic crunch. I have never heard that. So you have to suspect from the history and examination. And ECG, most of the time chest as seen here, can have some subcutaneous emphysema, mediastinal gas, and very clear heart border, and sometimes with this widened mediastinum. And they can have pleural effusions as well. Focus is again helpful to identify pleural effusions or pneumothorax, or sometimes you can't see anything due to the subcutaneous emphysema. Management is you have to very aggressively resuscitate these patients with antibiotics, and you have to refer this patient to counter 6 for operative debridement, but anyway, the mortality is high in these patients. Okay, so those are the big six. So those are the most critical diagnosis we need to think of. Most critical diagnosis we should not miss in the emergency department, but there are some other causes as well. I'm not going to talk about all these pathologies, but have an idea, even though other than these critical illnesses, there can be some specific condition we need to be addressed. Simple pneumonia, maybe may not be life-threatening, but that has to be addressed. Pericarditis without tamponade, yes. Unstable angina, yes. And pancreatitis. Those are very important causes to identify. And there are some non-urgent causes as well, like stable angina and viral pleurisy, pneumonia, especially in the history, if the patient is having fever, cough, respiratory symptoms, X-ray showing pneumonia, that is diagnostic. And post-coronary chest wall injury, so those are very benign condition, but that has to be taken after excluding the most life-threatening conditions. Cholecystitis can present like chest pain, and GORD, biliary colic, peptic ulcer disease, all can present. Herpes zoster, another very important diagnosis to be made in the emergency department. One take-home point is always, if a patient is complaining of pain somewhere in the body, you have to visually inspect. You can't just palpate it, the area under the clothes. So you have to see where it is actually so. If you actually see that, sometimes you can see a rash of herpes zoster. Sometimes you can see metastatic, you can see a breast cancer. So there are presentations of patients who are having breast cancers, just selling, just chest pain, tender. But unless you examine it, you won't detect that. There can be some infection, there can be some abscesses of the chest wall. So those are the things you need to identify and treat accordingly. Finally, this is one of the management algorithms I saw. Though there are many management algorithms available in literature, this is one of my most favorite ones. So let's go through this to have some idea of everything I have already mentioned. So what is the approach of a chest pain in the emergency department, especially with regard to the investigations to be done? First, patient comes with chest pain. My initial stabilization comes first. That is assessment of the vital signs, cardiac monitoring, IV access, oxygen. And if the patient is stable, focus history and examination. If the patient is unstable, we are here. So that we have to go for the airway breathing circulation stabilization. You have to treat arrhythmias and you have to treat other life-threatening causes. And if the patient is having stable vitals, the patient is stable, then you have taken history and examination, then you take the ECG. And if the ECG is diagnostic or suggestive of acute coronary syndrome, you have to, sorry for that. So can someone of you tell me whether you could hear me at this point?
Halfway through on the slide, you got muted, sir.
Perfect, thank you. And so that you could hear this part, no, I will just go through briefly. So you assess the vital signs and decide whether the patient is unstable, so that you have to stabilize the patient. If the patient is stable, you take the ECG to decide whether the patient has got diagnostic or suggestive acute coronary syndrome features. If you have any problem with the connection or the clarity of my talk, please let me know. Sorry for that. And so if the patient is having STEMI, you know what to do. If the patient is non-STEMI, you know what to do now. So always have a second thought whether I am dealing with a case of aortic dissection, just to exclude the aortic dissection. That is very rare, but it's not good to miss that. Fine. Next step. So if the patient does not have typical ECG changes, then you can go for the chest X-ray. Chest X-ray can be diagnostic of several conditions. If the chest X-ray is diagnostic of pneumothorax, you know what to do now. So you have to go ahead with the pneumothorax pathway. And if the chest X-ray shows widened mediastinum with the history of history and physical exam plus or minus risk score suggestive of aortic dissection, that is aortic dissection until proven otherwise, so that you have to go for the definitive investigation, that is CT autogram with emergency thoracic surgery consultation. And then you might see evidence of heart failure in the chest X-ray or pneumonia in the chest X-ray, and then you can go ahead with the appropriate management of heart failure and pneumonia. So that is where you stabilize the patient. ECG is not diagnostic of acute coronary syndrome, and the chest X-ray showing some possible diagnosis with pneumothorax, aortic dissection, or heart failure or pneumonia. Assume this patient didn't have any chest X-ray features. Chest X-ray, no obvious diagnosis. Then you have to think of other causes. What about PE? So if the patient comes with some kind of pain suggestive of PE, you can stratify the risk of PE with the Wales score, Berg score, or Geneva score. And then you know now, according to the scores, depending on the risk, whether it is low risk, intermediate risk, or high risk of PE, you know what are the investigations we have to do. Whether you can rule out, whether you can have to do a D-dimer, or whether you have to do a CT, PA, or VQ scan. Then once diagnosed, you know how to treat now. And then if the chest X-ray is not diagnostic, even though patient didn't have any obvious signs of acute ECG features of acute coronary syndrome, then you have to do cardiac markers, because as I mentioned before, history alone, ECG alone cannot rule out acute coronary syndrome. So that you have to add cardiac biomarkers and use risk stratification tool. Maybe heart, maybe TIMI, whatever it is. So if the cardiac markers are positive, that is there is some myocardial damage, then you know how to manage them. And then if the cardiac markers are negative, it may not be. If the risk is low and if the cardiac markers are negative, you have to think of something else, some other diagnosis, like diagnosis or increasing or higher risk of having major adverse cardiac event during next 6 to 8 weeks, so that we can use the cardiac risk markers and get some idea of the patient's age and decide whether this patient can be safely discharged. That means the patient has got some chest pain, there's no ongoing chest pain, normal ECG, normal troponin I, maybe serial troponin eyes, and the risk stratification shows that patient's risk is very low. So those patients can be discharged home once proper system to follow those patients up is there. And if still you feel that patient has got some kind of risk, you might need to admit this patient for further investigations. And if the patient has got some kind of pericarditis or tamponade, again, you have to go for the history examination and ECG features to see whether they suggest new features of pericarditis and pericardial tamponade, so that you can have a bedside ultrasound scan to confirm it and treat. And that is one of the very comprehensive flowcharts I found with regard to chest pain management. One of the most important thing I need to mention here is, even though I mentioned about a couple of risk stratification tools, these numbers, these scores are not just scores. Always we need to have that scores interpreted with our clinical gestalt, so that always clinical sense should be there, so that you can't just depend on these risk stratification scores. You have to put your clinical knowledge, clinical gestalt into the patient management decision making as well. So that is basically end of my lecture. And if there's any question, I'm happy to answer. Thank you.
Thank you very much, sir, for that very informative presentation. It's time to enlighten few queries. So far we have one question: how to differentiate a new onset ST elevation or depression from old one in emergency department?
Good question. That is a great question. So we can't identify unless we have an old ECG. We can't. So always from the history, I mentioned with the patient, you have got similar pain before. What did you do for that? Did you get any ECGs? Where are the ECGs? So if you can find from a clinic book or somewhere, you have to see the previous ECG and check whether it is a new one or an old one. If you don't know whether it's an old one, you have to assume it's new. At the same time, even though I mentioned about focus, point of care ultrasound scan, sometimes you can see very clearly there are some ball motion abnormalities, but you can't differentiate whether it's new or old. So same story for the left bundle branch block as well. You don't know whether it's new or old. If it is pre-existing, you have to go for the Scabos criteria. I didn't mention too much about that, but you will definitely have a similar some talk about these ECGs. So basically, you can't. And on the other hand, if someone might ask about Q waves. Q waves can be old one, maybe a new one, but Q wave itself does not exclude the candidate from urgent PCI or revascularization strategy. So that you have to do that.
Another question, sir. Drop by duration, any limitations?
Yes, drop by. Now we have our conventional troponin eyes. And now we have got in most of the hospitals and high sensitivity troponin eye as well. So both these assays measure the same molecule, no difference. But the high sensitivity assays can measure a lower level of troponin I levels, so that is more sensitive. So for the conventional troponin I, what we say is you have to at least wait for 6 hours. But in high sensitivity troponin I, you can do it within 2 to 3 hours. If you do a high sensitivity troponin I before 2 to 3 hours, you always need to repeat it in 2 to 3 hours again to see delta drop by, that is the change, especially for the patient who have got chronic elevation of troponin eyes, maybe CKD, maybe a cancer, might have some chronic elevation of troponin eye. For those patients, what you need to look for is a rise followed by a fall of troponin eyes, so that the things are the limitations wise, yes, as I mentioned, troponin eye can be elevated in some other conditions, many conditions. So that always you need to keep an eye of the possible other causes, maybe sepsis, maybe aortic dissection, maybe pulmonary embolism. So there are many causes. So always have a wide idea and broad view of the possible causes of troponin eyes.
So in GP setup, we give aspirin at and transfer immediately to a hospital. Is there any instances where they should not be given?
So if I go through that final algorithm I mentioned, so I think this gives a good idea of that. So if the patient is stable, obtain to early DCG and check administer AAC if patient low risk for aortic dissection. The only thing is if you have a high suspicion of aortic dissection, or if the patient has got aspirin allergy, yes, you have to avoid the aspirin, and atorvastatin is not in the proven list now, so it's not considered the stat dose now. So aspirin is number one. It is proven to be effective, and clopidogrel once it's confirmed, but atorvastatin stat dose does not do any major change of the to the outcome.
How to approach SAH presenting with ECG change?
So SH, that is a neurological emergency, sudden onset SH. Why you get ECG changes in SH? That's because sudden onset blood in the brain matter. That is a huge stress to the that can give rise to huge sympathetic drive and can cause huge sympathetic vasoconstriction in the body, which can affect the myocardium and cause a supply-demand mismatch, and that can give rise to various non-specific ECG changes that can mimic acute coronary syndrome, that can mimic unstable angina, that can mimic non-STEMI, that can mimic STEMI as well. So there are instances where the patient comes with headache, but due to some reason, the chest pain also have been there, and the patient has got these typical ECG changes, and patient have got fibrinolysis with the tenecteplase. So these incidents are there. So that if the patient has got significant headache, you should not manage ECG changes thinking that is acute myocardial infarction until you exclude an intracranial event. So basically, if the patient has got SH, you don't do anything for the ECG changes, just manage the SH.
Please explain about ventricular strain pattern.
Yeah, ventricular strain pattern is, it can be right ventricular strain pattern, it can be left ventricular strain pattern. So what happens is ventricle, due to some reason, maybe due to hypertension, maybe due to pulmonary or systemic hypertension, our ventricles have to pump against a bigger afterload than it's used to. That means it has to work hard. That muscles go through a mechanism of hypertrophy. And at some point they get strained, they get fatigued, so that there are some changes, so that you can see typical, if it is left ventricle hypertrophy pattern with a non-specific T and ST changes, specific T changes specifically in lateral and inferior leads, so that you can have, assume left ventricle hypertrophy with strain. So you can have the ECGs which shows left ventricle hypertrophy and non-specific ST and T changes, especially in lateral and inferior leads.
Does propping up cause any harm to pulmonary embolism patients?
Pardon, can you please repeat it?
Does propping up the patient cause any harm to pulmonary embolism patients?
No, nothing. Unless if the patient is in shock, obstructive shock due to pulmonary embolism, yeah, that patient needs to be light supine in order to maximize the brain perfusion. That's all. Otherwise, nothing.
Another question, sir. Can you please repeat what you said about Q wave previously?
The Q wave is now the Q waves. If the patient comes with chest pain and a patient has got Q waves, that can be old or it can be new. Sometimes, even though the development of Q waves does not have a specific time gap, so that even though patient comes with a STEMI, assume that patient comes with a STEMI and patient has got Q waves already, sometimes there is some idea if the patient has got Q waves, patient is not suitable for revascularization therapy. It's nothing like that. So even though patient has got Q waves, if the patient is having ongoing STEMI and ongoing chest pain, you can go ahead with the fibrinolysis therapy. I think those are the things which should be managed separately in acute myocardial infarction lecture. But let's say that is the basic explanation for that.
Can you please give a brief explanation on the procedure of needle decompression at fifth intercostal space?
So basically, patient is in front of you. Patient has got a tension pneumothorax. So basically, it's an emergency procedure. So you can use a needle, you can use a cannula, but the needle is better most time in emergency setups. So fifth intercostal space is our safe track. So initially in textbook descriptions, what we read, second intercostal space mid-capillary line. Due to it is discouraged, I will tell you that it is discouraged because depending on the patient's body habitus, due to the bulky pec majors, our needle length may not be adequate. On the other hand, if the patient is very thin and if the patient has not got a significant pneumothorax, that has a theoretical risk of damaging internal structure. So that to be safe and to be more effective, now most of the places they advocate using fifth intercostal space. That is fifth intercostal space in between mid and anterior axillary lines, just lateral to the pec major. Just clean it, and then one thing is, if you are in a really hurry, you can just put the needle in, or else you can put a syringe on with some air, and then you can insert it while withdrawing, so that you can see bubbling of air through the syringe. Then you can remove it and decompress it very easy.
If clopidogrel stat dose is given, is there a problem for primary PCI with relation to risk of bleeding?
No.
What size of needle is suitable for tension pneumothorax?
Usually we go for size 14 or less means large. Size 14 is there are some bigger dedicated needle decompression cannulas as well. I don't know whether it's available in Sri Lanka. Usual size 14 or less, that means bigger.
Okay. That's all we've got so far. So if there are no more queries, I would like to thank Dr. Chamara Berugodaarachchi for his excellent presentation on behalf of GMO Sri Knowledge Academy. Thank you very much, sir. And
Thank you very much.
thank you for the great audience. Here we are signing off today. Have a good day. See you next week.